Good afternoon. Thank you, Luis, for the introduction. Yes, I am a specialist in vascular and endovascular surgery, and now we move for a little bit out of school, and we are in the neck. And what I can do today is try to convince you that there is something interesting for development of also this discipline in the extracranial venous outflow routes. This is my disclosure. A chronic pathology that determining a primary chronic venous obstruction in the extracranial route, especially in the internal jugular vein and or in the adagos vein, was recently defined as chronic cerebrospinal venous insufficiency. CCSVI is the acronym. There is a huge variability in the prevalence of CCSVI, for example, in the first disease where we try to find out an association. It was multiple sclerosis. And this is one of the reason because the link between MS and CCSVI and also the associated endovascular treatment with venous PTA have been a subject of controversy and debate. Despite this, there are a number of observational studies reporting possible advantages by treating CCSVI in MS with balloon angioplasty. However, the available evidence is scarce and NICE encourages research on PTA for CCSVI in MS in the form of robust, controlled clinical trials. Our Department of Public Health in the region Emilia-Romagna in Italy decided to fund a randomized multi-center clinical trial in 2012. Brave Dreams trial is a randomized, double-blinded, sham-controlled, because the control group was treated with a sham angioplasty by the means of selective catheterization of the adagos and internal jugular veins to assess safety and effectiveness of venous PTA for MS treatment. The effect of treatment on neurological function is for the first time objectively measured by the means of instruments, not simple plus and minus score based on subjective neurological assessment. MRI outcomes are also primary endpoints and are the traditional parameters evaluated in clinical practice as well as in trial, evaluating drugs in this field. We also evaluated QOL endpoints to provide novel information on the effects of this intervention. To be honest, my hope was to give you for the first time in Madrid the results of the trial, but unfortunately I am still under embargo because till the publication of the trial I cannot give any kind of results. However, the steering committee of the trial authorized me to give the flowchart. We have about 200 patients assessed for eligibility, and 69 were ineligible because of exclusion or inclusion criteria or for the absence of associated CCSVI to MS. However, 130 were enrolled and 150 were randomized. 86 assigned to PTA and 44 to sham. And finally, the study is very small but is of high quality because more than 90% of people completed the follow-up. And I hope to give you the results next year at this point. What are the common causes of internal jugular vein flow obstruction? We can subdivide it into intraluminal obstacles, such as defective valves mainly, for immobility, orientation, long and longitudinal leaflets that are not capable to to open and close. External compression, and today I show you something interesting also for your clinical practice, and hypoplasia. This is an echo example of a long leaflet of a valve with a course parallel to and longitudinal to the vein wall and not transversal. The second picture shows you an inverted orientation of the valve. The sinus is directed to counteract the flow coming from the brain and not the opposite. Usually the valve present an orientation with the sinus which look to the thoracic, to the chest, to prevent reflux from the chest to the brain. This is exactly the opposite. And the other example of gross anatomy is a septum, not mobile septum. These are all causes of primary venous obstruction. This is a scanning electronic microscopy of one of these defective valves, and you may see that there is no endothelial cells. It's a fibrotic lamina capable to stop completely the flow. In this case, look at the angiogram. The valve looks like an axillary valve because it is oriented to prevent a reflux from the chest to the arm, not like a jugular valve. But when the first leaflet is open, it blocks the flow from the brain to the chest. This is an MRV that shows an HIV nutcracker, an external compression between the omohyoid muscle and the common carotid. However, whatever is the cause of CCSVI, or blocked outflow from the brain, now has been developed the catheter venography standardization. It's very interesting because there was a lot of discussion about the 50% degree of stenosis that sometimes is difficult to be evaluated, especially for intraluminal obstacles. So a group of Professor Veru developed this standardization and published it on the Journal of Vascular and Interventional Radiology. Automatic injection of contrast dye, 4 milliliter per second for 2 seconds, total 8 milliliter, followed by a fixed frame acquisition rate, 3 frames for 4 seconds, and after 2 frames per second for 8 seconds. Of course, same head and neck position and normal breathing. I want to show you now. This is a normal case. And normally, the clearance of a contrast dye in the jugular vein with this kind of protocol was calculated to be less than 2 seconds. This is a case of CCSVI, and you have 2 kinds of information. Collateral flow with a crossover from left to, I'll show you again, from left to right, and also a prolonged time of clearance, more than 6 seconds. This is what you may see in a phlebogram in a case of CCSVI. But this also is useful to measure if the procedure was effective. This is the same case. You may see that the collateral circle disappears immediately, and you have a very rapid time of clearance of the contrast dye. In that paper, 89% of MS patients showed a moderate or severe delayed flow through at least one of the two jugulars, and 79 patients showed a moderate or severe delayed flow through both IJVS. However, the pattern of CCSVI that I showed you are very challenging for the simple PTA. In fact, you may see in this paper published in the Journal of Vascular Surgery that we have approximately 50% of failure. So PTA is ineffective. What we did is to revise our case and to understand what are representations more susceptible of successful treatment. This is a case when you have a membrane or transversal not mobile leaflets, like in the case depicted. This is a perfect case to disrupt the membrane and the leaflet and to have a good recanalization of the jugular vein. And this leads, this is very important for what I show you in the next minutes, we may have a significant decreased gradient of pressure between the superior vena cava and the jugular vein. Presentation less good for PTA are long leaflet because usually can be when you inflate the balloon are simply lift up without disruption, and you may have some effects for a few months because of the dilation of the wall. But this usually did recur. And also are not favorable compression like the IJV nutcracker due to the omoioid muscle entrapment. As I showed you before, PTA is effective in case of short, stack, and symmetric leaflets. PTA is not a good treatment in case of hypoplasia, like those depicted in these angiograms. There is a huge representation of collateral circle, and it is very difficult also to individuate exactly what the jugular vein is. Now there is something about new indication to treat CCSVI. This is a paper recently published by a group in UK that show the impossibility to treat any 18 months girl needing vascular access for spinal osteomyelitis, and the internal jugular vein was not suitable because of CCSVI. The right IJV was affected, and this is depicted by atresia with multiple intraluminal obstacles, and the left was affected by valvular stenosis. They did SCD and catheter venography, and with PTA, the group was capable to recanalize the left internal jugular vein and to use it as vascular access with successful treatment of the infant. Another very interesting, we did 7 cases till now, and I show you a case because it's very well documented of high pressure hydrocephalus due to bilateral contemporaneous jugular nutcracker. The case is 70 years old woman with systemic vasculitis, intracranial hypertension with progressive ventricular enlargement, abnormal dilation of the cortical veins, and color Doppler study of the jugular system showed Louis something really interesting. You may see 2 contours of the ventricles respectively in December 2015 and October 2016 when the patient was again hospitalized for optic disc edema and a severe picture of intracranial hypertension. when the neurosurgeon asked me to perform a study of color Doppler of the neck, what I found was unbelievable, because as you may see in this picture, you may have a compass between the omohyoid muscle, H muscle, and the carotid that stop completely and block the flow bilaterally with very scarce and few collateral vessel. And this is all the scan. The shape of internal jugular vein, J3, is immediately after the jugular foramen, and J1 is the outlet into the chest. So at the point J2, that approximately is immediately down to the below the thyroid gland, was completely closed, and this was bilateral. This is a normal case for comparison on the left as compared with the jugular nutcracker of this patient. In this case, we decided to perform a novel operation. This is a ventricular drainage, just for monitoring the procedure in the neck. And we derived the intracranial pressure. This is the gross anatomy. You may see the omohyoid muscle very well. You may see the fingerprinting of the omohyoid muscle on the jugular vein wall. It's very clear, the nutcracker. And this was bilateral. This is the trace after the induction of the anesthesia, and we may have two kinds of information. The first information is the quantification of the intracranial pressure, was 16 centimeter water, and usually in supine position is between 0 and 5. Immediately after the procedure, there was a dramatic decrease of the intracranial pressure at 7 centimeters of water. Very interesting is the quality of the trace, because you may see that the first systolic peak is lower than the second one. This is a signal of intracranial hypertension, followed by the dicrotic wave. And you may see that immediately after the procedure, the two systolic peaks are on the same level, and there is a clear dicrotic wave respect to the trace, the pre-op trace. This is an example of monitoring the two CSF trace respect to the electrocardiogram trace. You may see the higher trace of the CSF preoperatively, yellow, and the dark one is, the green one is the CSF postoperatively. It is very clear. This is the pre-op respect to the post-op appearance of the internal jugular vein. Of course, this can be done also by stenting. We use open surgery in this case because the stent in this particular moment are still off-label. So we are surgeon, vascular surgeon, and we prefer to use open repair. But this, of course, can be done the same with stenting procedure. And you may see also below the monodirectional trace of the brain outflow directed to the right atrium. This is the perfusion changes, especially in the occipital part, seen by PET. So the metabolic activity increased 30 days from the procedure, as you may see easily by comparison. And the CT, measuring the volumetry of the ventricle, showed a reduction, a consistent reduction of more than 10%. Optic disc edema disappeared 1 week after the procedure. No drainage from the neurosurgeon was needed in this case. And we repeated this in our 7 cases. So this is, I think there is a group of intracranial hypertension where there is something in the neck that produces the effect. In 2017, the results of the Brave Dreams trial will be available. There are other new emerging indications for treating the extracranial veins. In case of hypoplasia, long and longitudinal leaflets, as well as in case of external compression by muscular compression, as in the case I showed you today, this cannot be corrected by the means of simple PTA. We definitely need of-stent devices specifically designed for veins, so with venous compliance mechanical properties, so the possibility to the stent to have a variation of the cross-sectional area in response to the change in volume and in pressure that are typical of the vein, especially in case of internal jugular veins, because this vein is particular because it's a pulsatile vein, because the right atrium pressure changes along the cardiac cycle are reflected in the so-called jugular vein venous pulse. So the device needs to be compliant with this change, physiological change in pressure coming from the heart. In the next International Society for Neurovascular meeting, which will be held in beautiful Taormina, there will be a first experience with new stent devices for veins that can be profitable, used also in the intracranial system and in the dura mater sinus and in other field of application linked with your daily job. Thank you for your attention.
Any questions?
Yeah? Very good.
Well, I mean, my question was, what kind of MS patients were chosen in this trial?
What kind of?
What, relapse and remitting, progressive MS?
No. I described 2 things. One is a randomized controlled trial, which was done in patients with relapsing remitting MS, but I cannot show you the results because I am still under embargo. So I simply showed the flowchart. The other cases were cases of CCSVI in young patients needing for survival of avascular arches that were treated by balloon angioplasty. And the second one was a series of cases with hypertensive hydrocephalus due to a blockage in the neck. So the neurosurgeon omitted to perform because the catheter in the ventricle was placed just for monitoring the procedure and was left out immediately after the procedure because we cutting the 2 omohyoid muscle we obtained a dramatic decrease of CSF pressure, of intracranial pressure. So there are cases of hydrocephalus. I do not have experience of normotensive hydrocephalus, but maybe a proportion of those cases could be with something that hamper the flow in the neck, in the cerebral veins.
Thanks.
Professor Zamboni, no, I am enthusiastic your theory. It's the third time you come here, because I think it's the new, it's not the new idea, it's the old idea.
Yeah.
For example, one time you come here with Venous pathology, the NEUROIMC, he come the neurologist very famous in Paris, Marie-Aimée Bousser and Professor Zamboni and other, and everybody talk with the stenosis of the lateral sinus, and you open and you are improve the hydrocephalia, improve the pseudotumor, improve some pathology. I think Alberto García Lafuente stay here and improve the tinnitus. I remember very well, but it's only the only attack the lateral sinus. Your thing is, I think, is for me best idea or more complementary is dilatation of the drainage vein of the head. But just a minute. But when I work in Paris with 1886, I remember very well Professor Alburquerque. Professor Alburquerque is the beginner of the study of the venous hyperpression, of the spinal cord lesion, paraplegia, paraparesia chronic, and have one study in 1976. The study from Alburquerque is the high flow in the left renal vein compromise the drainage vein in the spinal cord, and in this period is close to the core now or close to the surgery this vein. But your initial, or for me initial, for your initial research, I think is very interesting, because it's not only open, it's maybe change the drainage venous all in the body. It's not only in the cervical region. In athigos, in thoracic, it's different. In lumbar, it's different. And sometimes it's very difficult to know you have hyperpression because you are stenosis or you are collateral venous circulation going in this. For me, it's very interesting to work.
I thank you, and to have more discussion and less slide, I omitted to present 3 studies which found the same in Parkinson. For example, transversal sinus to the left and coupled with internal jugular vein hypoplasia was found in 3 different latitudes. A very important, significant susceptibility factor for Parkinson. And this was done in Detroit, the same was in Shanghai, and the same was in Milan. Same protocol of MRV, and because the left part of the venous system drain the basal ganglia. And this is very interesting also. Alburquerque noted the compass between the mesenteric artery and the aorta that stop the left renal vein, and this is significant for myelitis in case of stenosis, for example, of the proximal valgus. So there is a lot of very interesting pattern that could play a role in understanding inflammation and deterioration of a certain nervous system. Maybe it's not the only cause, of course, but is certainly a contributor to edema and to chronic inflammation.
Do you remember Dr. Ameriso, Professor Ameriso, Sebastián Ameriso from Buenos Aires, in one NEUROIMC talk with the amnesia global transitoria with this physiopathology? And my question is, what is your opinion with the, have you a benign hematoma or hypertension hematoma or hematoma, intracellular hematoma? Do you think sometime, or you are the possibility secondary to stenosis, the venous brain drainage? Because I read some work.
I think that this could be only in case of malformation of the vein. In the group that are called venous malformation, but sometimes are innocent malformation in the brain, maybe if you should have unpaired outflow, you may have probably a rise in pressure and something like hemorrhage that can be, of course, worsened by the presence of CSVI or a condition of compression or something like this. But I do not have experience in the field. Thank you very much.